Hey, it's Rob Fitzgerald. Welcome back. Another quick session in lab medicine. We're going to talk about how to use the laboratory to figure out what's going on with your liver or your patient's liver. And then we're going to focus on interpreting bilirubin. So there's a bunch of different forms of bilirubin, and they tell you different things, and so we're going to try to make sense out of that. So what can the laboratory do for you with liver disease? So one, it can tell you, is there a disease present? If so, it can tell you what kind of a disease is it. In particular, we can focus in on, is it hepatocellular damage or is it a cholestasis, biliary tract kind of a problem? It can also give us information on prognosis. For example, looking at coagulation, if you have enough damage to your liver and you're not synthesizing liver proteins, in particular the coagulation factors, that's a bad prognostic sign. So we can also use different tests to figure out what is causing the liver damage, and that is often helpful for identifying treatment strategies. So liver function, liver is really a very powerful organ. It's synthesizing, pretty much it synthesizes all your proteins, everything pretty much except for immunoglobulins. So albumin, coagulation factors, transferrin, binding globulins, etc. are synthesized in the liver. It has important catabolics, so it's breaking down things. It's important in detoxification. If your liver is not functioning, essentially you die within hours or days, depending on how bad your liver is poorly functioning. Important effects on carbohydrate metabolism, as we talked about, protein synthesis, lipid metabolism. It's a storage organ, so you store your iron there. It's important for excretion, detoxification, helping absorption of foods. All of that is related. So we can use the liver to the lab to help figure out if it's a diseased liver or if there's a systematic or systemic disease that's causing liver damage as a secondary problem. So really important in drug metabolism and clearance. Drug-drug interactions are important at the liver because of the cytochrome P450s that are doing the metabolism, and you can get enhancement of metabolism, or you could get inhibition of metabolism. Some drugs are hepatotoxic, and so we have good lab tests that can really direct life-saving therapy if we can identify, one, is the drug present, and two, do we have hepatotoxicity. Hepatitis means inflammation of the liver, and it can be caused by viruses, it can be caused by drugs, and so we can use lab tests to help figure that out. So they talk about liver function test, and people talk about an LFT, and oftentimes they're including both liver function as well as hepatocellular damage markers. And so I would prefer to think about it as hepatocellular markers, cholestasis markers, and liver function. Liver function meaning the ability to synthesize things or to conjugate things and excrete. And really those are important distinctions because you can have hepatocellular injury without having liver function damage. If the hepatocellular injury, you have enough reserve in your liver to make up for that. So our best markers of hepatocellular injury are transaminases, so AST and ALT, aspartate aminotransferase and alanine aminotransferase. So we commonly just talk about them as transaminases. Bilirubin can also be an indicator of hepatocellular damage. If we have enough hepatocellular damage, those hepatocytes swell up and we get increases of both a conjugated and total. And we'll talk about what is a conjugated and what is a total and what is an indirect bilirubin and what does that mean. So tests of biliary tract disease, so this is really more along the lines of a cholestatic problem, so the ability to excrete. Alkaline phosphatase is really high. Alkaline phosphatase is an enzyme that is really high concentrations in the in the biliary tract, and so if you have biliary insult, you get an increase of alkaline phosphatase. It's not specific to the liver, so there are bone forms of alkaline phosphatase, there are cancer forms of alkaline phosphatase, and so we oftentimes combine several, like a GGT with an alkaline phosphatase. If the GGT is high and the alkaline phosphatase is high, that tells us that we have a liver issue versus a bone issue. And in that case, the bone issue, the GGT would be normal, gamma-glutamyltransferase, and the alkaline phosphatase would be high. So as we said, GGT is also high in the biliary tract. Bilirubin, both conjugated and total, and so we're going to really break down the bilirubin here in a minute, but basically if you have cholestasis, you cannot excrete conjugated bilirubin, and you will back that up and you'll get an increase of both conjugated and total bilirubin. So test of etiology, so it's great. We've identified, is it hepatocellular or is it a cholestatic problem? Potentially, is it a synthetic problem? And then what is the cause of that? What's causing the liver issue? So a variety of hepatitis antigens, and we'll talk about those in our next quick hit. Viral antigens, so hepatitis C antigen is telling you that patients are still infective. So antigen implies infectivity, whereas antibodies imply a response, and depending on which antibodies are present, it could imply immunity. We also use alpha fetoprotein. Typically it's a fetal protein, but in hepatocellular cancer it also is elevated, and so that would be a test of etiology. Immunoglobulins, if you have hepatitis, you get an immune response, so you have inflammatory and your immunoglobulins will be high, and oftentimes that would be a polyclonal hypergammaglobulinemia. So if you did a serum protein electrophoresis, you would see a broad band in the gamma region due to the different immunoglobulins, versus MGUS, where you have a single monoclonal immunoglobulin, or multiple myeloma. Autoantibodies, if you have autoantibodies, they could be against ANA, could be attacking the liver, so that would be a test of etiology, why you have an elevation of liver enzymes. Iron, transferrin, and ferritin. Hemochromatosis is iron overload with tissue damage, and the liver is one of the organs that's being damaged, and so we can look at iron, transferrin, percent saturation, and figure out if we're having an overload of iron, which is causing liver damage. We also measure copper ceruloplasmin, which is helpful in identifying the potential for Wilson's disease. So focusing in on bilirubin metabolism and the different bilirubin tests that we use and talk about when we are talking about liver disease, where does it come from? So hemoglobin breaks down, so red cells break down in the spleen. The hemoglobin molecule, the iron, is recycled, and bilirubin is formed, and we call this indirect bilirubin. We call it indirect because it doesn't react very well with the reagents that we use in the lab. So we have to add something to the serum sample to get it to react with the reagent. So it's indirect, and this is unconjugated bilirubin. And so this is the lipid-soluble form. It is transported around bound to albumin because it's lipid-soluble and it's in an aqueous solution. So it binds to albumin. It's taken up by the liver, and the liver conjugates it, and it puts a glucuronide and potentially two glucuronides on it, making it water-soluble. The glucuronides are carboxylic acids, making it more polar so it can be excreted. So this is what we call direct bilirubin. And so in the laboratory, the two most common bilirubin tests we're going to talk about are total, and total would be both unconjugated with conjugated, and we talk about a direct bilirubin. And so direct bilirubin is primarily the bilirubin glucuronide that's water soluble. So we essentially the way it works is we run it once and we get the direct, we add an accelerant that's going to solubilize the unconjugated, and we get a total. And if we want to know how much of unconjugated is there, we simply subtract out the direct from the total and we get unconjugated. Bilirubin, once it's formed in the liver, gets excreted through the bile duct as a glucuronide, and in the gut it gets deconjugated. There's glucuronidases that form bilirubin again. Bilirubin gets further metabolized in the gut to urobilinogen, which gets further metabolized to the stool pigments, which give feces its brown color. And so why do we care about all of these? We care about urobilinogen because it's a good marker of intravascular hemolysis. And so what's the deal there? So intravascular hemolysis, we have a lot of red cells being broken down. So we've got an increase of hemoglobin. We've essentially increased here. We've increased the unconjugated bilirubin. And typically that's going to be a finding. You know, whatever bilirubin gets to the liver's still working fine. And it's forming a lot of bilirubin glucuronide, which is going to form a lot of bilirubin, a lot of urobilinogen. And most of that goes into the stool, but some of it goes back into circulation. So, and urobilinogen is excreted in the urine. And so if we have an elevation of urobilinogen in the urine, along with an increase of unconjugated bilirubin, that's suggesting that we've got intravascular hemolysis. Bilirubin also undergoes enterohepatic recirculation. So once the glucuronides are cleaved, it's again lipid soluble and can cross membranes. And the last form of bilirubin I want to mention is what we call delta-bilirubin. This forms when we have cholestasis. And so when we block this, so this is essentially our liver dumping into the gut, we get an increase of direct or conjugated bilirubin. That blockage flows back into the bloodstream, and we get an increase of conjugated bilirubin, which then covalently binds to albumin and is a long reservoir. So we might cure whatever was causing the cholestasis, but they have a long-term excretion of direct bilirubin, and that could be due to this delta bilirubin. When things like bilirubin bind to albumin is this big protein and it has a long half-life, so they stick around a lot longer than you would normally expect. So that's our bilirubin metabolism. And just to focus in again, so we measure two forms of bilirubin, typically a conjugated and a direct, a conjugated and a total. Total is typically less than about 1.2 milligrams per deciliter. And we simply subtract out the conjugated from the total to get the unconjugated or indirect bilirubin. It's the end product of heme. It's transported unconjugated, bound to albumin. It's glucuronidated in the liver, and it's excreted in the bile. It is light sensitive, and so if samples have sat around, then you could get an artificial lowering of the bilirubin. That's sort of analogous to what they do with bililights. So unconjugated bilirubin, we don't really report that. We report a direct and a total, and we expect everyone to make that simple subtraction and figure out what was the unconjugated. And that's simply the total minus the conjugated gives us the unconjugated, or the total minus the direct is another way of saying that. So where do we get elevations of unconjugated bilirubin? Without significant amounts of conjugated happens in hemolytic disorders, so we talked about that. So if you have intravascular hemolysis, really you have an increased load. Whatever gets to your liver, the liver clears, but you have the spleen is clearing a bunch of hemolyzed cells, and you get an increase of the unconjugated. Gilberts syndrome is a transport defect and a conjugation. Crigler-Naijar there's a couple of different forms of that, and basically you have a glucuronide transferase deficiency, and so that makes sense. If you can't conjugate it, you would get an increase of unconjugated in both of those syndromes. newborns don't have the synthetic capability, and again, that's what we get concerned about, and that's why they get put on bili lights, because unconjugated bilirubin can cross the blood-brain barrier and cause neurotoxicity. Cirrhosis, you can have, you can get it in cirrhosis, but it doesn't always happen. Elevations of conjugated bilirubin, really it means cholestasis. So if your bile flow is blocked and your liver has already formed these conjugated bilirubins, it's going to back up into the bloodstream, and that's where we're measuring it. Elevation of conjugated bilirubin says, to me, cholestasis. So elevation of both of them, hepatitis, that makes sense. Hepatitis, you've got inflammation, your cells aren't working as well, so you can't conjugate it, and when you do conjugate it, you can't excrete it. Cirrhosis is a very similar mechanism. A post-hepatic obstruction, that's cholestasis. It backs up, you get an increase of the conjugated, and if you continue to be unable to excrete that, you also have an impact on the ability to actually conjugate it. Dubin and Johnson and Roders are deficiencies in the ability to excrete conjugated bilirubin, and so that would make sense that you would get both of those. Drug-induced cholestasis. So pretty much all of those are talking about a cholestatic mechanism. When I think about an elevation of conjugated bilirubin, I'm thinking some component of cholestasis. Delta-bilirubin is the conjugated bilirubin stuck to albumin, and it's not normally present, but it can cause a prolonged hyperbilirubinemia. Bilirubin in the urine is telling you that you've got a cholestatic problem. Why is that? That's because the only bilirubin that shows up in urine is conjugated bilirubin. And so if you have an elevation of conjugated bilirubin, then it can spill out into the urine, and when they do a urinalysis, it shows up as hyperbilirubinuria. So that's always abnormal, and it's seen in basically all of these situations where you have some component of cholestasis. And as we said, unconjugated bilirubin is not water soluble, so it doesn't occur. It doesn't get excreted into urine. So it has to be conjugated bilirubin to get into the urine. So that's a quick overview of some of the basic lab approaches to detecting liver disease. And our next session, we'll talk a little bit more about etiologies. Thanks for tuning in.